To address today are 5 things. One is the principles of our therapy. Second is the chemotherapy we give. Third thing is the growth factors we give, the prophylactic antibiotics, and the principles of stem cell collection. In terms of our treatment, our basic philosophy is that myeloma is a very resistant disease, and for those who have looked at bone marrows after radiation treatment, the only cell that survives the treatment is basically the plasma cell. That's the only cell you still see, and so those are extremely hardy cells, and low doses of chemotherapy are not going to cut it. You can get a complete remission, but you will not get a long lasting response. So we want to go as quickly as possible to the most effective treatment, which is transplantation. But unfortunately you cannot do transplantation until you have stem cells. So we first need to get to the stem cells. The way we typically will collect stem cells is by using deep-phase chemotherapy. And not so much because it's such a great anti-myeloma combination, but mainly because it allows us to collect as many stem cells as possible. We try on an average to collect about 20 million CD34 cells. If you would use growth factors only, half of the patients would fail, would not have that amount. And why do we want to have so many stem cells? First of all, we do 2 stem cell transplants, and the more stem cells we give per transplant, the safer the procedure is. You have to remember that most of our patients are in their 60s and 70s, are not spring chickens, and they benefit from having recovery as quickly as possible. In addition to that, since it's very difficult to collect once you have given 2 transplants, any time thereafter, we want to be sure that if the patient would relapse after 6, 7, 8 years, we still have stem cells in store that we can give at that point in time. Yeah. So, deep-phase is a combination of dexamethasone, P for platin, A for adriamycin, C for cyclophosphamide, and E for etoposide. This is typically given in 24-hour infusions because it has been our experience that 24-hour infusions instead of short infusions are more effective. Plus the fact that adriamycin is less cardiotoxic if you give it over a long period of time compared to a short infusion. So the cisplatin, the cytoxin, etoposide can be combined in one bag over 24 hours. The adriamycin needs to be given in a second bag over 24 hours, so those patients will typically have 2 bags to carry. And every 24 hours the bags are exchanged for a total of 4 days. In addition to that, we give the dexamethasone orally on days 1 through 4 and 8 through 11. And the 1 through 4 usually is not an issue, but we shouldn't forget that they also need to have a second pulse of dexamethasone between days 8 and 11, usually when they're already out of the hospital, but it's always good to remind patients that they need to have that. The growth factors we use are Neulasta and Aranesp. We used to give Neupogen to mobilize patients, and the Neupogen was typically given in a divided dose, a morning dose, an evening dose, and about 10 milligrams per kilogram. So most of the patients ended up with 24 to 28 injections. To make it a little easier on the patients, we switched to Neulasta, 6 milligrams on day 6 and 13. Instead of 24 to 28 injections, they now have 2 injections, which helps. Most of the patients appreciate that. We also showed that mobilizing with Neulasta was at least as effective as mobilizing with Neupogen. And actually, when we used those stem cells, the platelet count recovered significantly faster in patients on Neulasta compared to those that were on Neupogen.
Was there an explanation for that?
No, because it's not that they collected more. They collected exactly the same numbers. We gave exactly the same numbers back, and neutrophils did not recover any faster. But the platelets recovered to 50,000 much faster with Neulasta, significantly faster after transplantation compared to the Neupogen.
You might be mobilizing earlier progenitors that
It could be,
potentially are
yeah.
giving platelets.
It could be, but we really didn't have a good explanation. Obviously, if we would have collected more and would have given more stem cells, it would have made sense, but that was not the case. The other growth factor we use is RNAsp. It has always been my intention to try to avoid as many transfusions as possible. And we used to give RNAsp in a prophylactic basis so that by the time they were getting their chemotherapy, their hemoglobins were in the 12 range or higher, and they could go through this without any transfusions. And before they get a transplant, their hemoglobins were around 12, and they could go through transplants without any transfusions. Unfortunately, the guidelines, as you know, have changed, and we can only give RNAsp if hemoglobin is less than 10 grams per deciliter, and patients have to be on chemotherapy. So trying to crank their hemoglobins up is no longer an issue. It's no longer a possibility. In addition to that, you would think it would make sense to take into account the fact that a patient is young or old, that the patient has cardiovascular problems or no cardiovascular problems, that the patient lives at an altitude at sea level versus 6,500 feet, that all those things would play a role. But no, it's like a blanket statement, 10, and that's it.
Is that guideline only? My understanding for the guideline, it's for solid tumors that they have it, not for hematological.
It's for hematological.
As well as
yeah, it's based on the data in solid tumors, because there is no hard data that there is an increase in thrombotic problems with RNAsp or with Procrit compared to not giving it. There's no evidence at all. But this is just derived from the head and neck cancer studies. Yeah, so that's somewhat unfortunate, and has certainly led to many more blood transfusions than we would think are necessary. But that's the reality we deal with. And so, but as soon as the patients are on DPACE and they have started the chemotherapy and their hemoglobin is less than 10, give them RNAsp, try to get it up as quickly as possible, and we typically give that every 2 weeks. In addition to the fact that people feel better when their hemoglobin is up, it is also much more effective to collect stem cells if the hemoglobin is not too low. It's much easier to see the Buffy code with a higher hemoglobin than if the hemoglobin is very low, and then the plasma and the red cells and the white cells all are a little together, and in the end you collect more red cells doing it that way, and you make them even more anemic if you do it that way. But we have to deal with the realities we need to deal with. In terms of prophylactic antibiotics, DPACE will lead to severe cytopenia. Almost all those patients will have neutrophil counts under 200 at one point in time, which last for about 3 to 7 days, based on how much prior chemotherapy people have had. There's an exceptional patient who hasn't had any treatment before. This is their first treatment you give. They never will become thrombocytopenic, never will become neutropenic, but that's the exception. Most people have had treatments before and will become severely cytopenic. So they are at high risk of bacterial infections, and that's why they're on prophylaxis with Cipro. They're at high risk of fungal infections, especially yeast infections. That's why they're on fluconazole. They're at high risk of shingles, and that's why they're on acyclovir. Most of the infections that we see when they're on prophylactic antibiotics are related to either gram-positive infections, line infections with Staph epi, or resistant E. coli, basically E. coli resistant to Cipro, which is very common. When we see a gram-negative infection on Cipro, it's almost always E. coli and a resistant E. coli to the Cipro. So those antibiotics are typically given until day 9, and on day 9 we try to stop it, because at that point in time we have to also think about how are we going to optimize our stem cell collection, And all those antibiotics to some degree suppress the bone marrow function and suppress the amount of cells you can collect. So we used to stop it on day 9, all of those things. Now we will continue with the Cipro after we have had one Pseudomonas infection, which was sensitive to Cipro, but except for the Cipro, all the other prophylaxis is stopped. The stem cell collection will typically start when patients recover their counts. And that is usually somewhere between day 14 and day 17. But it depends largely upon how much treatment people have had before they come to us. If they have had little treatment, it will be much closer to the 14 days. If they had extensive treatment, it can be 17 to 20 days. Stem cell collection typically is done through a line that is placed into the jugular vein and makes it easy to do large volume collections. We used to collect about 15 liters of exchange about 15 liters of blood with a stem cell collection. Now we do about 30 liters. And we have also shown that if we do 30 liters compared to 15, that there is no decrease in the second half of what you collect compared to the first half, that you collect as much in the second half. Once you go over 30 liters, then you start to lose quickly, and there was no reason to do more than that. And those procedures on average last about 4 hours for a 30 liters collection. And most of the patients will get their stem cells collected in 2 or 3 days. If they have had extensive prior treatment, this may take up to 5 or 6 days before they get to their 20 million. 90% of our patients will achieve the goal of 20 million. And another 7 to 8% will be somewhere between 15 and 20 million. And then the ones that have had, especially the ones that have had a lot of Revlimid or a lot of Melphalan before, they will have lesser collections. Hello.
Hey, Dr. Tricot.
Yeah.
So what I would ask you guys to do is pick a question
Yeah.
that you want to make sure you troubleshoot the process.
And whatever we encounter.
Yeah, and logistics of how, and make sure you're asking the questions so that everybody hears them.
Yeah. 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 For galactomannan, that's positive, yes.
Yeah. So we still keep the
VFENT, yes.
same thing.
Okay.
Okay. Thank you.
Yeah. Sorry for that.
You're on stem cell collection.
I was on stem cell collection, yeah. So there are 2 ways. So basically what you try to do with we used to use bone marrows, get the patients to the operation room to collect from their pelvis, but we never could collect a large amount of cells. And we can collect much more from the peripheral blood. And it used to be that for the counts to recover post-transplantation, when we used bone marrow instead of stem cells, the time to recover an ANC to more than 500 was about 20 days. To recover platelets to more than 50,000 was more than 28 days. Now with the peripheral blood stem cells, we typically get our neutrophils back on day 11 or 12. We have more than 500, and the platelets on day 14. So there has been a tremendous reduction in the duration of the cytopenias, which has made it possible for us to not only use this intensive treatment in younger patients, but also in older patients. Older patients would have difficulties being cytopenic for 3 weeks, but to be cytopenic for about a week, going down on day 4, coming up on day 11, usually it's very feasible. Again, the rapidity with which the bone marrow will come back depends upon how many stem cells you have given. We will typically give 5 million CD34 cells, because the 5 million CD34 cells or more assures you that you will have rapid recovery with a very narrow margin. If you give, for example, 2 million cells back, then the average time to recover will be about 13 days, but you will have the 90th percentile here and the 10th percentile there. So this is a much larger range. If you go with 5 million, you will have something like this here. This is day 11, and this will be day 12, and this will be day 10. So they all 90% will have recovered in those days. The way stem cells are collected are two major ways. One is growth factors only. Growth factors only is good if your goal of stem cell collection is 5 million or something like that for a single transplant. If you want to have more than that, chemotherapy is the best way to do that, because it ensures you that 90% of your patients will get to where you need to be. I don't know how familiar you are with stem cell collection, but basically the principle is that once the patients recover their counts, you look at the CD34 count in the peripheral blood. Once the CD34 count in the peripheral blood is more than 10, you hook up the patients to the apheresis machine. The apheresis machine will remove the blood and separate it in two parts. One is the red cells and the red cells and the plasma, and that will go back to the patient. That's about 99% of all the blood, and 1% is the buffy coat. It will be siphoned off in a bag and will be frozen, and then you measure how many CD34 cells you have in there. In principle, we always do 2 days of collection, even if we achieve our goal in 1 day, because sometimes there are problems with the freezing, and the bags of 1 day are totally gone. And if you have given this guy high-dose chemotherapy and you have no cells to back up, big problem. So that's why we typically will collect at least for 2 days. It would be very unusual to have 2 days of problems, but technical problems with freezing happen from time to time. And although the viability of the cells when you thaw them, of the CD34 cells, is typically in the 90% range, we often find viabilities of only 50% or 60% when we thaw the cells. So I think that's in a nutshell what we do, and so I hope that by understanding the basis of this, that it will be easier to understand and to treat those and to help those patients when you see them on the floor. And
you guys have had the most experience. You want to start asking questions, at least about the logistics and expectations of what happens to those patients, and specific questions that Dr. Tricot can address.
I guess my first question is, and that is the question we call you most of the time, initially was like, we consider no matter what the chemotherapy starts at 8 p.m. or 9 p.m., that will still be a day one.
Yes, but again, it's the day one, but it's a 24-hour infusion.
Right.
So yeah.
Because the important thing was day 6, because in solid tumors we go Neulasta shot after 24 hours. So here there is no as such of having a 24 hours gap between the chemotherapy and Neulasta shot. It will be day 6.
Yes. There is data in solid tumors with myelosuppressive treatment where they have given the Neulasta the last day of the chemotherapy, right, and 24 hours later. Right. The 24 hours later was more effective. But there is no data in hematologic malignancies, and there is no data to say that 18 is different than 24 hours. There's only data between the day of the last chemo and the 20. Yeah. So when you look at guidelines, it will tell you that you have to give it 24 hours after the last chemotherapy, based on this study that compared the same day versus 24 hours later. And so it's easier if the chemotherapy can start early in the day, but for practical reasons that's almost always impossible, and usually it starts around 2 to 4, 5 o'clock. Yeah.
Your last issue, I think, is the reimbursement. Insurance companies like to reimburse only if it's given after 24 hours. So that's I don't know if you've navigated that. I can.
No, yes, but usually our patients have a cap on. They have a certain amount of money that we get for the
Sure.
for the induction treatment.
Oh, for you
So
it's-
exactly, and for most of the patients, it's not an issue because whether we give it or not give it, yeah,
I was
yeah,
wondering if you
Yeah.
got around
Yeah.
that, but you
Yeah.
seem to have gone around.
yeah,
So-
yeah.
Okay.
In the same context, I have a question is, let's suppose if the chemotherapy starts at 5 or 6 later in the evening, obviously the patient will complete the chemotherapy at evening.
Yeah.
Sometimes they request that, you send them home next day because of whatever reason. And my understanding is that if they go next day and they have the same follow-up clinic visit, usually it's not covered.
You can only cover one visit a day. So if they are discharged today and they're seen the same day in the clinic, either the discharge can be billed or the visit can be billed, but not both of them. That's for sure.
Why is that? Because you're two different providers. Why would that make a difference? Is it part of the
Because
induction package, you mean, or?
for us, it would not make a major difference because that package would be the same anyway. But I mean, in principle, you can, if it's done with the same specialty and they are acting as our specialized BMT associates, could not do two services the same day.
But they're acting as the general internist for these patients on DPAs. Actually could.
It could. I don't know. We would have to look into
Okay.
that. Yeah, yeah.
Just wondering.
But I don't think it's a major issue because it's the package again, and whether we charge twice or once or none, it wouldn't make a difference. Yeah.
There have
Same
been
as the surgery.
times, just in relation to that, because of this delay in leaving from hospital, sometimes patients prefer that they leave next day, and
Yes. Yes.
that obviously makes their length of stay one more day beyond. Is that
Yeah.
a problem?
I don't know how the insurance companies would deal with that.
Get that pressure to.
I understand. I fully understand it. The question is whether the insurance companies would cover for reasons that are not medical but are more social to have an additional day of hospitalization.
I think with the hotel in place, potentially people could go to the hotel.
Yes,
and spend the night
yeah,
in the hotel.
yeah,
So
yeah.
I think that outpatient part is going to be available to patients who are receiving this type of chemotherapy. So we may have a way around or reducing that length of stay for that patient. We just set it up, so it's starting
Yeah.
to roll out
Like,
the
it could be
outpatient
less
part.
and less,
And you actually might even have less DPACE patients on the inpatient unit.
Yes, we will try to do as many as possible.
Majority of them might
yeah.
be moving to the outpatient.
Yeah.
So, and there will be this hotel. So, we may let you know that the patient could be discharged. They could go to the hotel, spend the night there, and then go
Yeah.
out back to wherever they wanted to go. At least not using hospital resource, using our
Yeah.
resource for the BMT program.
But typically, as you know, those patients, because they are severely neutropenic, they stay around here until they have recovered, and they don't go home until they have collected the stem cells.
And this is coming. So as we connect the two programs, the inpatient and outpatient service, we'll update you. I'll be updating you as that comes forward. But
How do you want us to go about giving RNS as an inpatient? I think this process needs to be a little bit more streamlined, is what we are thinking. That
Yeah. So
like, there's a patient right now
Yeah.
who's 9.2 today, and I asked the pharmacist, is there a process in place? Do you want me to initiate and just let you know to sign the order? But then comes the process of consenting, which I believe we cannot do as non-oncologists.
no, but any of our PAs or I can do that for you. But we need to know.
Okay.
Yeah. Yeah.
So we just go with the same process of emailing you. the-
Yes, exactly. And say this patient is a candidate for RNS, but doesn't have a price form signed.
Right.
Can you please get this done? We'll do that.
has that worked okay in terms of communicating through the email? If you sent an email, you get the.
Yeah, something like non-urgent matter, I think we have been able to, but we just wanted to make sure we continue this.
Good.
Yeah.
What other logistical issues have you faced?
Any complication associated with the therapy we should look or should watch during the stay?
During the stay, in principle, adriamycin can be cardiotoxic and cytoxin can be cardiotoxic, but in reality, I don't remember a single patient who has had problems cardiotoxic problems with that type of chemotherapy. There's the occasional patient who will be a little fluid, who has a limited renal function. You give them all this fluid and they will be somewhat fluid overloaded. I think that's probably the most common complication that we see.
You guys watch weights and you give Lasix appropriately if needed, okay?
Lasix, are you typically okay with that? Giving if there's a weight gain of more than 2 pounds?
Well, typically I would only give Lasix if there is evidence, not if there's a little edema peripheral, because those patients will then stop their fluids and they will go home and they don't drink as well as possible and whatever. So I would be a little careful, but if the patients are getting fluid overloaded and getting short of breath and whatever, obviously that's, yeah. But that would be, in my opinion, the only reason to give Lasix. Once you give Lasix, they get into hypokalemias and hypomagnesemias and all other types of problems. Yeah.
When we talked to you before, you mentioned fluconazole 100 milligram daily. Is acyclovir 400 milligram BID.
Yeah.
As well as Cipro 500 BID. Right?
Nice, yeah.
And you also want us to start patient on omeprazole.
Omeprazole.
And Lovinox.
Yes.
So just to, and then we'll continue Lovinox shot as a
Yes. Those patients usually are typically not very mobile,
right,
when they get their chemo and whatever, and they're at high risk of DVTs, and most of that can be prevented by giving Lovinox.
And from my side, one situation I encountered is a patient getting back with what looks like febrile, but he has a catheter as well. Usually and typically, I mean, if we are getting this patient at night time, you prefer just start IV antibiotics and not to touch the catheter, or just take out catheter? I mean, this was a situation 2 times occurred with me. That
was that the apheresis catheter or the port?
No, the
apheresis catheter. If the collections are done.
If not.
If the collections are not done, if they're not done and they're febrile, but they shouldn't be neutropenic. We shouldn't be collecting or having a line already placed when they're still neutropenic.
Right.
We typically will wait until we see the white cells moving up and they're not neutropenic. So I would think that the most likely source, if they have an infection, they're not neutropenic, the most likely source is that they have staph epi infections in the line and that they should be on vancomycin. Yeah. But if the cultures remain negative after 2 days, I would stop it, because the vancomycin is certainly going to affect the counts, how much you can collect.
But we are asking about the overnight coverage, like you leave the catheter in and start the
and then went through the
Yeah. If they have the catheter placed for collection and they're not done with collection, you leave the catheter in and you start them on vancomycin. And if after 2 days all the cultures are still negative, stop.
A catheter-related infection, to really pull the catheter, you have to prove it's the catheter.
Right.
So unless it's really boggy and it's painful and red and ugly looking, or the cultures came back gram-positive and you're still waiting for them, and you've got a day for collection, my advice would be use the bank, bridge some time, and put the catheter once you're done. 'Cause that catheter is a big one and it's harder to put back in.
And typically, staph epi can be eradicated with antibiotics, in contrast to fungus, to yeast infections or gram-negatives. Do you know why it's so difficult to eradicate gram-negatives from catheters and yeast?
They found that slimy layer and they kind of cling onto it.
No. The catheter at the end has multiple layers. It looks like that, but there's actually all types of layers around this. And the bacteria, they just go in there. And you give your antibiotics and it comes out here, but it doesn't touch anything over here. And it stays there. And the only way you can eradicate is by taking the catheter out. But that's not the case for gram-positive Staph aureus would do the same thing, but Staph epi would typically not do that. That's easy to eradicate. But VRE, gram-negatives, yeast, you would have to take the catheter out because they're hiding in between the layers of the the
So
catheter.
the future would be you put another catheter in, cut the tip of the catheter and come back.
Yeah.
That would be the future.
Yeah.
You're not there yet.
Yeah.
The collection will be as an inpatient or it will be?
Collection is always done on outpatient basis. Yeah, the exceptional patient who comes in with neutropenic fever. Yeah,
He dealt with some cardiomyelitis.
yeah, but
If
but that's
patient is inpatient,
exception.
then it will be inpatient.
Yeah.
Inpatient is
It
already
remains
outpatient.
for a long time.
It's outpatient procedure normally. Yeah.
What other problems have you faced that you want Dr. Tricot to answer?
So patients coming in with non-chemo or chemo-related complications, neutropenic fever, how do you want us to handle the concentrated support?
People who come in with neutropenic fever, the most important thing is that within 15 to 20 minutes after they come in, they are on antibiotics. That there is no big delay. As you know, if you have a Pseudomonas infection and you don't give proper antibiotics within 4 hours, there will be already a 25% ultimate mortality rate. If you wait 6 hours, it goes up to 50%. If you wait 24 hours, it goes up to almost 100%. The key thing is getting the antibiotics in quickly. So don't think about, should I first give fluids or other things. First thing you do is you give your antibiotics. Once that's in, then you can start to think about, well, maybe it's a little hypotensive and I should also give some fluids and other things, but get the gram-negative coverage. People die of gram-negatives, not of gram-positive, so don't first do the 1 hour vancomycin infusion and then thereafter the gram-negative antibiotic. You start with the short duration gram-negative antibiotic, and when that's done and you still think there's a reason to give vancomycin, then you start your vancomycin.
I think his question was for, like, do you want to be notified?
Notified.
Do you want to come and see the patient? Or is there going to be a consultant present at the time?
If they are admitted and everything looks stable and straightforward and whatever, I don't think there's a need. If there's to notify, but if you don't feel comfortable, if you see this is a little too overwhelming, I would like to be notified. Yes.
So one of the things we've done for the leukemia service is that there is a leukemia consultant present.
Yeah.
We haven't really talked about the, having a consultant actually cover this as a service.
At some point in time, when there is more people,
So the point being is, I think we're going to develop it. If it looks like an uncomplicated neutropenic fever and you're comfortable, that's fine. If you're not, maybe just call them.
Exactly.
Tell them, I've got a patient, this is what's happening, can you come and see this patient, just give us some insight on what's going on. I think that at least him or one of his teammates will come and see the patient.
Yeah.
And how comfortable are you if we involve ID service in case we have to for all?
I have no problems at all. I would feel uncomfortable if you feel that they are needed and you wouldn't do it.
Yeah. The ID, is there a specific person that you've already worked out?
Yes, we have Dr. Ince, and and that works very well. She is very conscientious and she sees all our patients. Unfortunately, she's now a month in Turkey, but she will be back.
Any other questions?
So for stem cell collection, is it if a patient has a fever, would that prevent you from? So I've had a couple times where they've been called me from the outpatient. They have a clinic where they go to get the collection, and they called me and said, "Should we go ahead?" The pathologist was wondering.
Yes, you get the patients on antibiotics and you start the collection.
Mm-hmm.
Things are different if people have a fever but are hypotensive. If you then start to remove fluids when they're already hypotensive, this patient you're not going to be able to collect. In no time will be in severe shock and he will have to stop anyway. But if they have normal blood pressure, antibiotics and start the collection.
I mean, I might be wrong, but I think when you're mobilizing patients for stem cells, sometimes the actual stem cell itself will release cytokines and
there's possibility.
So the reality is, unless there's evidence of sepsis, where you're seeing heart rate
Septic
is high,
shock,
blood pressure is low, fever, tachypnea, tachycardia, something that's telling you, no, this is more, I think you should go ahead with the collection. So
Yes.
simple fever, start your antibiotics, but continue
But
the
yeah,
collection.
and if you have any doubts about that, give me a call.
Yeah, that's, and you know, I think that would be, so uncomplicated fever. But fever shown with SIRS, then I would definitely not collect, and you'd have to assess the patient. So then that they call you, go down and see the patient, or ask the right questions. You know, how's the patient's temperature, what's
Yeah.
heart rate, you know, you can give Tylenol, start your antibiotics, etc.
How sick does the patient look? If some people have 39 and feel kind of okay, and others, they're like
Does this
dying.
happen at night when they're collecting? When
So sometimes this patient was kind of evening, 8 o'clock or something.
Okay, so they're later in the day when there might not be support staff to answer these questions. So are you
But-
getting a lot of calls like this? No.
That should not be,
Occasional
because
ones,
yeah,
okay.
the people who are doing the collections typically don't want to stay after 5 o'clock. So-
Right,
because
they do
once
it-
they have done the collection, they still have to freeze the stuff, and they want to go home by 5 o'clock. So this will be the exception, that they really start very late in the day, and it's usually very hard for us to convince them to stay and do a collection once it's too late in the day.
Dr. Tricot, the patient who's undergone TPAs and is very close to the stem cell collection, or maybe even afterwards where they're heading towards a transplant, are these better served by us versus BMT team? I mean, you know, there are 1 or 2 occasions where we are tossing around. I call Dr. Silverman saying, can you take this patient because he's heading towards the transplant, versus I just want to hear some words from you, or you're comfortable us taking care of those patients.
In principle, I think once they are done collecting, they should be taken care of by the BMT people. But as you know, there's limited staff at this point in time, limited doctors. There might be that we have too many patients for too few people, and the main principle should be that we give the best possible care to our patients. And if we jeopardize that care by having too many patients taken care of by too few people, then I don't think it's a good thing to do that, and they would be better off in your hands.
Any other questions or concerns? So this is your opportunity to ask.
Any issues that you have come across as an outpatient?
You know, expectations from
And,
your perspective.
the main things that we see is that people don't go out on their prophylactic antibiotics. That has happened a few times. That they have not gotten their Neulasta, or has not been arranged. So I think there's still part, even if you don't give it inpatient, it should still be part of your responsibility to set up the day 6 Neulasta and making sure that that's being given. And that don't forget that they still need to have a second pulse of dexamethasone between the 8 and 11.
I think now there's a nice script that comes out
Yeah.
as a part of the plan, and
I've not had those issues lately.
Yeah.
No.
When you are doing the Americans,
Yeah,
really
yeah.
seeing Decadron,
Yeah.
you pay 211.
Yeah.
You remember.
You give all the patient the medication in house before they leave.
Yeah. Yeah, but in the beginning, when people were not so familiar with
Sometimes
this,
they leave late and their pharmacy and down are closed.
but having a pharmacist available in our team has helped us tremendously.
Okay.
Okay?
All right. Thank you very
Good.
much.